welcome. Thank you for being with us, Alan.
Thank you.
Fantastic. Well, by way of introduction, I'll say in terms of the formalities, Cosima, an ex-NHS doctor, product leader, all about really, I think, taking new practices out of the lab and into use, presumably by particularly public health or medical professionals. That seems to be the gist of your work.
Yes, exactly.
Can you help us bring us to life with just one example of that in practice?
I guess I spent some time in California helping spin out a new next-generation sequencing test from a lab in Stanford, where we set up the first clinical version of this test. It was basically liquid biopsy, so that is finding tiny, tiny fragments of cell-free DNA in the blood, but normally that's for cancers. This time this was for infectious diseases. So we had a panel that could detect about 1,000 different pathogens and started out in research use, and we took the lab live, basically now rolling it out across hospitals across the US to patients with leukemias and rare cancers who have kind of bizarre bugs. It's very house.
And it really was as simple as that, I'm sure.
Yeah.
No bumps on the road. Right, well, I want to explore those bumps as we go. But Molly, tell us a little bit more. You're the John Black Professor of Bionanoscience at the University of Oxford. Now, one thing that drew my attention, you led a interdisciplinary research program at Imperial College, but particularly in your work in biosensing technologies. Forgive my sort of ignorance in that area. What do we mean by that?
Well, so I'm really an academic. I'm based most of the time in the university, but very, very interested as well in translation, and have founded a number of spin-out companies. In terms of the biosensing, we've approached this in different ways. The main aim is to make point-of-care tests, so tests that you can use out in the community without expensive equipment, but make them much more sensitive. So take something like a COVID lateral flow test, but make it work a lot better. So you can detect diseases earlier and more robustly as well. And the way we're doing that is by developing new types of nanoparticles, so new types of materials that give stronger, more robust signals.
So I think there are going to be sort of a lot of points of light as we begin to open up for questions. But when a technology doesn't get adopted, what stops it getting adopted? Because we want the lessons from the front so we can sort of oil these wheels. Cosima?
It's a great question. We talked about it on the stage, and it's many, many different factors. I think it really depends on where you're actually launching the technology, into which part of the health system and what kind of technology it is. So something where it's a basic fundamental scientific discovery, such as liquid biopsy, even that will have trouble depending on which part of the health system it's going into and what the kind of clinical workflow is and how the money flows. So as an example, there was a company called Ariosa Diagnostics in the US that developed a liquid biopsy for non-invasive prenatal testing, so basically checking for mutations and hereditary diseases in fetal amniotic fluid. Instead of testing for those in amniotic fluid, you would take a blood test from the mother and detect the fetus's DNA in the mother's blood, which was revolutionary because what it did is it basically displaced a test down the line that was actually putting a needle into the womb. And that was one where things got adopted so quickly because the alternative was expensive, painful, risky.
Risky with risks.
Exactly. Yeah. On the other hand, if you've got an innovation that's more operational, that can be really difficult because all parts of the health system are different.
Generalized question, where leads the world on health tech innovation? Where do you look to for inspiration? And I'll ask Molly you that same question, actually, but Cosima first.
So I hate to say it, but I spent 4 years in California, and America is, if I think about the two areas that I focus on, digital health, America is streets ahead. And unfortunately, it's partly because there is a business model that underlies it. You can get paid by insurance companies and by employers. And equally, on a kind of diagnostics angle, they also have a really dynamic ecosystem there. So, yeah.
Okay.
In that area. Genomics, UK, obviously. We'll say that. Chris is in the audience.
I'm going
so
to former
head
of
that.
Genomics England. Chris Wigley would agree with that. Molly, but by contrast, where do you place the UK in context on this? Where should we be proud? Where must we do better?
So I was at
MIT, actually, in the States before moving to Imperial College. And I guess one of the things I've been pleasantly surprised with setting up a research group here is actually the quality of talent that you can bring in, the people that you can actually attract to do great science, which is why it's really important that we keep as easy mechanisms as possible to let brilliant people from all over the world come in and be able to contribute to that great science. But I do think that this sort of concentration of great scientific minds that we've been able to attract in the UK is good, and we have to really, really treasure that and promote that.
Yeah, good.
Yeah.
And biggest area where we must do better. Forgive the UK-centric question, but briefly on it.
Well, I mean, funding, of course, but also ecosystems to make sure that inventions that happen in universities and things like that get translated properly. And I mean, wonderful news. Yes, was it yesterday or sometime this week that we got accepted, back into the
Rejoining Horizon, yes.
Yeah, that's amazing. So,
yes, keeping
all those links.
Okay, so we can ask you about developing new products, about working with government, probably as well, about academic research, but also about presumably connecting right through to members of the public. I don't want to put you on the spot too much, but who would like to get the ball rolling? I see your hand there. I'm looking around for other questions in the space as well on this healthcare subject. Let's come down here. You don't have to introduce yourself, but if you'd like to, you may.
Thank you. Good evening, both of you. Of course, Oli, I met throughout the day. I am Mani Janaki Raman. I work for the London Stock Exchange Group. And we are, there's a big issue, right, in terms of, you spoke about funding. We are facilitating at LSEG, we are facilitating a mechanism where we want to invest in UK-grown startups. And we recently came up with a notification that we will actively promote it, and we have asked pension funds to invest in startups as well. The question I have is around what can we do more in terms of promoting UK money to invest in UK startups.
And in particular, health startups. I'm leading you, but that's where you want. Okay, Cosima, have you got thoughts?
Yeah, I think one of the challenges, particularly when it comes to digital health startups, because often what they're trying to do is improve the operations of something, right? Deliver care in a digital way, is that investors look at it and don't see a market in the UK for that because of the way, the challenges with NHS adoption, and, there are smaller markets outside of the NHS, but that really is the big barrier. And so a lot of digital health companies go to the US. I think if we could start to think about how I don't have an easy answer for how we get the NHS to do that, but that is one big factor for investors, I'd say. Yeah.
Okay, now much work to do. And on that relationship with the NHS, what would be your top advice for innovators, entrepreneurs? You must have seen some lessons learned the hard way.
Top advice. It depends, I guess, on what you're doing. But the top thing I'd say is to really know which part of it you're going into and how the funding flows. So I help startups building digital health diagnostic solutions. And what we do is we go and we do just loads of interviews with general managers who have the budgets, who understand how things are paid for. Yeah. And that to me is just the number one most important thing. And unfortunately, you kind of need to design your product around that funding. In fact, I met someone the other day who is really successful, Ivan, he's got a startup and I've forgotten the name of it, but he actually went and he looked at a new budget and a new funding model and built a business around that funding model. And obviously it is designed to help care for patients, but I think we don't do enough of that here, and in the US that's kind of all they do. So, you need a balance.
Oh, I need to know who this is. Not Ivan Beckley, is it?
Yes, exactly.
There you go. What a legend he is. Yeah. Had his degree funded by DeepMind, did you know
Yes,
that?
exactly.
Yeah, there you go. Absolutely brilliant guy. And by the way, he took a detour from his medical degree to go and do a computer science degree.
Yeah.
Which raises the next question. To what extent are healthcare professionals of today fluent enough in tech, Molly? That's the challenge.
Well, I think both ways, right? Are tech people fluent enough in health?
Fair challenge.
Needs?
Okay, one at a time then.
Yeah, I think it's a sort of age-old question, really, that applies to all complex science. If I take even the example of when you're doing research, if you're doing very multidisciplinary research, we see it all the time. You know, I hire computer scientists and I hire surgeons and I hire chemists and engineers, and a lot of their entry into the group is actually understanding the language that the other one speaks. And it takes a long time, you know, for people to be able to actually realize what the other disciplines are saying and interact in the right way. So being able to essentially understand each other better, take the effort to do that as well, take the effort to sort of self-educate as well as other programs that might do that will definitely
But in terms of
useful.
design, today's medical students, how tech-fueled are those courses?
Well, the courses, and I don't know about the courses, but maybe you have a better idea, but I know that so I left medicine 8 years ago, and at the time went into product management to go into tech. And I see now, not a kind of few weeks goes by when I don't get a message from someone talking about leaving medicine to go into tech. So to me, there's a tidal wave.
There's a lot of
people
good jobs
leaving.
for medics in tech, that's for sure.
And more medics who understand both, either they go into data science, machine learning like Ivan, or they go into product management.
Yeah.
So I'd say that that's less and less of a problem now. What's more of a problem is everyone leaving and needing to, we still need people on the front line.
So thank you. More questions. We've got one and then two. Brilliant, thank you. Now, if you just go next door, if that's right, and then back to Tracy, thank you.
Hi, I'm Neha. I'm actually a current medical student who's I'm taking a year out because I would like to go and pursue computer science. So this is mainly aimed at you, Cosima. So I was wondering if you could tell me a bit more about your journey leaving medicine, kind of what prompted that and what that was like, and if you have any advice.
Absolutely. I hate to encourage more, but I guess we also need people in the field who understand, in technology, who understand what it's like in hospitals. So it's really, really important. I took a year out. I did medicine as a graduate, and then I took a year out during med school and went to work at an accelerator with a couple of different startups. And then I went to a tech program called Singularity University in California, which back then was kind of very at the cutting edge of things, which now we talk about all the time, but it feels... so that was really what kind of catalyzed and opened my eyes. And I spent, I guess, some years building up what I called escape velocity. So just doing side work as a product manager and while I was training and practicing, and then eventually got a job. So it takes a while, and medicine is, unfortunately, still, I think, a very constrained and rigid system. I guess the best advice I had was from Daniel Kraft, who was speaking earlier about 10 years ago. He said, finish your medical degree and practice, because that makes a huge difference just in terms of your understanding of how everything operates. And
Helpful. Daniel Kraft on this stage tomorrow, forgive me.
Yeah, we have, I always have actually, at pretty much every point in running my academic lab, have medics within the group pursuing PhDs, and that is fantastic because they input not only into their own project but into all the other projects that we have going on in the lab. You know, when we have our group meetings, group discussions, they'll say, well, that's a lovely idea, but it wouldn't be used in practice, etc.
Molly, how worried should we be about what Cosima seems to be hinting at, a little brain drain away from?
Well, I think you definitely don't want a brain drain away from medicine, but the point is medics can be useful in many different places.
That's true.
We need to have more flexible training programs that enable people to come in and out, because the reality is it's incredibly useful to have people who understand technology practicing.
Gosh, because one thing about what Ivan was doing,
Yeah.
he was being the maverick innovator there.
Yeah,
That could have been
exactly.
designed into his path. Another question here, and then we'll go back. Do I see offers here? Brilliant. Thank you.
Hi, I'm Tracy, and I just had a question which is around the bugbear I have with the UK system, medical system, and owning your own data, medical data. What do you think needs to happen for us to be in a situation where we can own our own medical data and flip between, just imagine a world, your GP, your private healthcare, your NHS healthcare, your optician, your dentist, so that you actually can get to the point of root causes and own where you're going in terms of your health. It's something that is obviously being looked at by NHS technology, but there is an element of NHS owning it, and therefore they will not make it interoperable. So what is the What's the
Good
thing that
question.
needs to happen?
Team, please hold that thought. We'll take our next question here, just in the middle here, in the stripes, and then please feel free to field accordingly. Thanks.
Hi, I work in a cancer research lab developing AI models to predict secondary breast cancer from H&E slides. I'm interested to hear what your views are on kind of a route to clinic for AI-based tools, what the blockers are, what the kind of desire is within the healthcare setting, and how we can work towards acceptance of those kind of tools.
Right, so two quite different questions. Route to clinic for AI-based tools, and Tracy's question on owning our own data, having access to it at the very least.
Probably both more for Cosima, to be honest.
I can answer Tracy's, but maybe, I'll start with that. I guess, to me, there's two different things. There's owning the data and owning the journey. And I think there's a lot of work going on, the blockers to owning the data. I wouldn't say it's because of the NHS. It's a lot of the time the interoperability questions are about the big electronic health record companies like EMIS and Cerner, who have a vested interest in commercially in controlling access. But the NHS is doing a lot of great work to bring a lot of data into the NHS app, which has been taking great strides, and actually compared to other health systems, I think that's going to be really exciting for us here. If you look at the States, your health data is in Kaiser, it's in Sutter, it's in all the different hospitals, and you can't have access to it. I think the second question of owning the journey is really important, because we've got to strike a balance between greater autonomy and looking after your health and being educated and understanding, but also at the same time, too much information can cause more harm than good. And at a certain point, it becomes complicated and one needs a guide. And so I think there's a balance on that side of things, yeah.
And we've all fallen foul to Googling our symptoms, and finding we have some very rare disease.
And Molly, your space of early diagnostics, which I'm also really passionate about, is really interesting, but it brings problems where you have self-tests where people find things that then are false positives or lead to further interventions that aren't needed.
Yes.
So
Yes, we're sort of always 3 clicks away from death, really, aren't we? If we ask Google.
Normally 1 click. I always find it on the first.
It's probably much higher than it was. Yeah. And thoughts on that journey through and out of the lab?
Well, I can't speak specifically to AI apart from to say actually how excited I am in seeing a lot of the developments in how AI is being applied to imaging, particularly in cancer actually, but it will be applied in so many, and is being applied in so many different health areas as well. But that's a bit outside of my area. Yeah.
To me, it's about what is the AI being applied to, and in your context, I haven't worked in that space, but it's if you were to take a machine learning model that you need to integrate into an electronic health record to predict bed flow states across a hospital, that to me terrifies me in terms of implementing it and getting someone to adopt it. But in terms of an AI algorithm within a device that's looking at HLE staining, histology, to me you're going into an industry that's very well developed in terms of bringing new software into hardware and then selling that. And so I see. It depends on what you're applying it to, but I think there's very exciting space.
Yeah, no, thank you. Right, I'm keen to get more questions. I see you there, Maria. Welcome.
Thank you very much. I'm Maria and I work in AI ethics, and I work with a former orthopedic surgeon, and I've seen how he applied the same duty of care managing personal data, understanding that those numbers are about people's life. And my question to you is, how do we educate and incentivize data scientists to have this mindset, this duty of care about the data that's in front of them, knowing that the way they crunch it impacts lives of millions? Thank you.
I can start. So that's a question that I have thought a lot about in terms of the training about do no harm that you get as a doctor that then permeates a lot of kind of how I work in tech and often isn't shared, and it depends. And I think that as a data scientist, there's very, very good controls and systems in place for how we control and secure data, but we haven't taken that to how we then use it and process it. So I think if we could maybe extend some of that regulation and kind of guidance and framing into how the data is then processed. That could perhaps be the starting.
I would say as well that data management in general has gained much more focus over the past years. You know, I remember when I started off in research, and you sort of applied for a research grant, and you know, maybe you got the funding, maybe you didn't, but now when you apply for a research grant, you know, you need to have a proper data management plan. And certainly if you're applying for a research grant in oncology or something like that, you need also patient representatives and all these things.
Yeah,
so
that's a change.
You know, that is a change.
Can I ask you specifically on that? Well, numerous patents filed to your name, you know, at least 4 spin-out companies based on your research. How would you supercharge UK spin-outs? Because, you know, I've been guilty of trying to coach too many inventors into being entrepreneurs. I probably could have been a better matchmaker over time, but that might be a red herring. What's missing?
Well, so a few things would be helpful. I already mentioned funding, but, you know, access to entrepreneurial talent, you know, is a very big thing. As well, and then also actually the way that universities spin out in the UK is very different to how it was, for example, when I was at MIT. You know, it's a different vision for how much equity the universities take, and you know, this has impacts then on the investment and things like that.
So how would you change that?
I would want people to maybe be a little braver, to take a few more risks, you know, and really run with things. Yeah.
But the net result
is
that
be faster.
The inventor owning more, less, the university.
No,
the university being too greedy.
That doesn't matter. But it's more about, you know, moving faster rather than quibbling over, you know, who gets X% or whatever.
Okay.
You know,
no reasonable.
just run with it, get it to patients.
Okay.
Yeah.
Cosima?
There was a really interesting piece of research done by Nathan Beniak, who's at Air Street Capital, and he surveyed hundreds of startups in the UK about the percentage that the universities have taken, and compared it and looked at in the US. And from my understanding, we are really bad on that front. Particularly, we take a lot of, we actually really interested in kind of cuts of the revenue later down the line rather than the equity, which hamstrings the business later on. And the percentages are like, some of them are in the order of kind of 30 to 50% for some universities.
Well, it's very variable from university to university.
Totally.
So it would be better if it was standardized across the UK, so that it didn't matter what university you were in.
Interesting, yeah.
And then also that it was perhaps more mirroring the kind of thresholds you have in the US.
Thank you both. I guess a final question, really, our theme question, if you like, for CogX this year: how do we get the next 10 years right now? It can sound flippant to ask for your 1-minute answer to that, but it's been helpful on this stage to get some provocation from our guests. What do we need to pay more attention to, double down on? What's almost underhyped sometimes we need to talk more about? Where does your mind go, Molly? And how we get that
I mean,
right?
I mentioned this actually in my talk on stage. You know, I work a lot also with different groups in Africa, and I have a huge passion for making sure that the technologies we're making are accessible to everyone. You know, that's very, very important to me. And I think that is something that certainly engineers and technology-focused people should be thinking about more. How 100%. Can we make technologies more accessible?
Yeah, thank you. Cosima?
Yeah, I think for me, at Our Future Health, we're really focused on building this big database. If you were in the talk earlier, 5 million people with linked genetic health, lifestyle, environmental data. And the whole point of that is because we want to accelerate translational research. So as Jack mentioned earlier, you know, during the pandemic, we managed to trial and launch the vaccine in the space of months that would have taken years. And we can do that. We just need to have the systems in place, the data, the access to the participants. So that, to me, I think is a really good area to focus on.
Yeah, really helpful. Thank you. And just joining dots, we've got Dr. Jack Crendler with us. Very good to see you, Jack. Chris Wigley, I think, lurking behind a pillar. Very nice to see you, Chris. And then for this session, most of all, to Cosima Gretton. Thank you so much for being with us. And, of course, to Molly Stevens as well. Please join me in saying a huge CogX thank you.
Thank you.